Well, good afternoon, ladies and gentlemen. It's my very great pleasure to welcome you to this GARFIELD Symposium here at the 2013 European Society of Cardiology meeting. These are my own disclosures. I'm Ajay Kakkar, Professor of Surgery at University College in London and Director of the Thrombosis Research Institute in London. And what I wish to do over the next few minutes before dealing with some obvious housekeeping points is to try and explain why it's important that we have outcomes registries such as GARFIELD, why in fact we're here today, to provide you with an update on where we've got with this important independent initiative over the past year, and then take you of course through today's agenda and introduce you to our distinguished panel of members of our steering committee who are going to present to you some of the insights and perspectives that have been generated as a result of this past 12 months' activity in the GARFIELD Registry. We know that stroke is increasingly seen as a global health problem, with many millions of cases every year, and an important proportion of all strokes attributed to underlying heart rhythm disorders, particularly atrial fibrillation. We know that in the presence of atrial fibrillation, a disease, if it is of aging, that the risk of developing stroke is fivefold increased, and that patients who develop stroke in the background of atrial fibrillation have much poorer clinical outcomes, a higher morbidity and mortality, and importantly, a much poorer functional outcome. What's striking is the consistency with which we in clinical practice fail to provide interventions that would in themselves help alleviate and reduce the risk for the development of stroke in the background of atrial fibrillation once identified. In terms of cardioembolic stroke, over half of it is attributed to non-valvular atrial fibrillation. And it's striking once again, with all of this knowledge about the epidemiology, about the risk for the development of stroke in the background of atrial fibrillation, that we continue to fail to provide interventions, particularly anticoagulation, that could have a profound impact on not only improving outcomes for the individual patient, but a profound impact on population health, and of course the appropriate utilization of valuable and scarce resources in our healthcare systems. If we look here at the use of anticoagulation from 10 years ago in the EuroHeart survey to prevent stroke in patients with known atrial fibrillation, we see that despite a well-recognized risk score at that time, the CHADS-2 score, to help us identify those patients at greatest risk for the development of stroke in the background of atrial fibrillation, that with increasing stroke risk, there was no obvious increase in prescription for anticoagulant therapies that would, by at least 2/3, reduce the risk of stroke in those already identified atrial fibrillation patients. And it remains a vitally important question in clinical practice. Why are we so reluctant to provide anticoagulation? Because if we look at the first cohort of the GARFIELD Registry, we see that little appears to have changed. With increasing risk for stroke, here the CHADS-VAS score, computed in newly diagnosed patients with atrial fibrillation who have been followed prospectively, there is little substantial increase in the use of anticoagulation with increasing risk for the development of stroke, and indeed about 40% of patients remain unprotected despite all the evidence from vast numbers of patients, many tens of thousands, in contemporary clinical trials that demonstrate the benefit of intervention with anticoagulation to prevent stroke. So we have a large amount of data from randomized clinical trials, but we have a disconnect with real-life clinical practice, and it's the insights from outcomes research in unselected populations of patients across the world that will help us understand how best to improve clinical practice through the appropriate and responsible introduction of innovations to prevent stroke in appropriate patients. Now, where are we in the GARFIELD Registry? Well, the design, just to remind colleagues, is of that of 5 sequential cohorts that will eventually include 55,000 patients, 50,000 of whom are newly diagnosed stroke patients, followed prospectively from within 6 months of the diagnosis of their stroke. Cohorts 1 and 2 have now completed recruitment. Cohort 2 with some 11,690 patients, and we commenced recruitment to Cohort 3 in the sequence of 5 in June 2013. And as of yesterday, there were some 24,256 patients enrolled in some 30 countries around the world. In Cohort 3, 4 new countries have joined the programme: Switzerland, Turkey, the United Arab Emirates, and the United States. Now, the purpose of the symposium is to share with you some of the insights and perspectives that this huge data set, followed prospectively, allow in terms of better understanding the burden of disease, the burden in individual patient populations, the impact of comorbidities on outcomes, and the opportunities, as I said earlier, for us in clinical practice to bring the advantages of innovation in stroke prevention therapy to our patients. And I'm very privileged to be joined today by my co-chairman, Professor Werner Hacker from the University of Heidelberg, distinguished physician and chairman of neurology there, who will co-chair this symposium and who is also a member of the GARFIELD Steering Committee. And you can see here the programme for our ongoing activities this afternoon in the symposium. Now, what we'd very much like to encourage is interaction with the audience here this afternoon. So please do ask your questions, either by completing the question cards and holding those up. A hostess in the room will come and collect them and bring them to the panel, or by standing at the microphones and indicating you would wish to speak. What we propose to do are to take questions in a panel discussion for the last half hour of this symposium. So please hold your questions until then. And during that panel discussion, Professor Hacker will also present a case, 2 cases, to